Diana Rojas works for WHO One Health program. She's a medical doctor with masters in tropical infectious diseases, and she has spent her life working on outbreaks prevention in developing countries. She joined WHO in the middle of the pandemics, June 2020, and she's been the technical lead of chikungunya and Zika, and she is also leading the WHO Global Alliance for arboviruses and expanding the collaborations to other parts of internal, external stakeholders in the world. So we look forward to how she will bring the global perspective and what WHO is doing in this amazingly important area. Thank you so much for our patience.
So let me start saying that One Health is the heart of preparedness, prevention, and control of vector-borne diseases. You cannot control a complex disease and a disease like this one without the One Health approach. We have from 70 to 80% of the re-emerging and emerging infectious diseases have a zoonotic origin. So sometimes when I talk about dengue, Zika, and chikungunya, they say, but why are you going to use the One Health approach if the main reservoir are humans? I say, yeah, but some centuries ago, it was a zoonotic disease, and it just the virus adapted, the mosquito adapted, and now it's a human mosquito human transmission. So we have to always keep an eye on that interaction between the vectors, the pathogens, and the humans. And when, like currently with dengue, Zika, chikungunya, we're in the amplification by human-to-human transmission. With yellow fever, for example, we are in the animal-human spillover of viruses because we have a vaccine. So we have been able to control those spillovers, but they occur. And a few years ago, there was a very large yellow fever outbreak getting in the south, very close to Sao Paulo, very close even to Rio. So these are threats. And I'm just talking about the usual suspects, dengue, Zika, chikungunya, yellow fever. But there are hundreds of arboviruses that are circulating. Most of them currently are not causing a human disease, but they are just waiting for the right time, the right environment, the right vector to have spillovers. So we have the drivers of transmission. We have the environment. So we have deforestation, for example. So usually the environment is one of the link that changes the most. So deforestation, the changes in biodiversity, climate change, as we have mentioned before. Then in the animals, the intensive farming and agriculture and pollution. And then from our side, the urbanization, migration, and the global mobility. So this is like a puzzle. You put all the pieces together, and if something is not working well, there is a risk that something is going to happen, right? This was mentioned before, so the population at risk for Aedes aegypti-borne infection. And I do say Aedes aegypti because we always usually talk about Aedes aegypti and Aedes albopictus, but if we say Aedes-borne infection, there are a lot of other Aedes mosquitoes that are not the ones that we are talking here. So we have 4 billion people that are at risk for this, to get infected of any of those viruses in all the 6 WHO regions, so in all the continents except for Antarctica. And dengue, Zika, chikungunya, and yellow fever are the Aedes aegypti-borne. Yellow fever, the urban cycle of yellow fever, because there is also a selvatic cycle of yellow fever. And then, so we have almost 130 countries with dengue currently circulating. Chikungunya has been detected in about 115 countries. And Zika, then we are publishing the update for Zika in the next few weeks. And we have more than 90 countries that have already reported Zika, like globally. And yellow fever is still located in South America and in the African region. So these are the countries that reporting cases of Aedes-borne diseases. We have to update it. This map was updated in October and is already outdated because every time it's changing quickly. So for example, you see there Italy, it's in purple, so it means that they just had chikungunya transmission. They had an outbreak of chikungunya in 2007. well, now we have to color it that they have more than 2 viruses that have been circulated, because now dengue is also circulating. France has detected autochthonous transmission of dengue, Zika, and chikungunya. And then, so we are updating all of these maps, and now we have to update them even more often. So in light blue, you can see that the majority of the countries have 3 of the or more of these 4 arboviruses co-circulating simultaneously. Then you have in green those that have just 2 viruses circulating, and then and then you see the specific colors for those that just have 1 of them circulating. So as you have co-circulation of these viruses, then it just makes sense to have an integrated approach, because you have a common mosquito. Of course, there are similarities, because dengue, Zika, and chikungunya, they look very similar the first days of symptoms. So when the Zika emergence in the Americas started, everybody thought, well, initially people thought it was measles or rubella, and then people thought it was dengue because it looks like dengue, right? And then everything was disentangled, and then people realized that it was Zika, and the same with chikungunya. So it just makes sense to have them all together. So that's when we came up with the Global Arbovirus Initiative. So while everybody was working on the pandemic, I was in charge of writing an initiative to prepare for the next, if the next disease X is an arbovirus. So we came up with this Global Arbovirus Initiative that has 6 pillars. So the first one is about monitoring risk and anticipation. So if we don't monitor risk, then how are we going to prepare, and exactly where are we going to focus all these activities? Then reducing epidemic risk is about strengthening capacities in the local levels for early detection, epidemiological investigation, and early response. The third one is about strengthening entomological environmental surveillance and vector control, because they go all together. The fourth one is about preparing and preventing pandemics, or in the case of arboviruses, will be a public health emergency of international concern. And this is how to bring all the stakeholders together to agree and share data to act on time and prepare. Then the fifth one is about enhancing innovation and new approaches, which is the research and development part. So here we have been discussing with different partners the need of vaccines, the need of diagnostic tools, which is a huge gap that we have on arboviruses, because, for example, dengue, Zika, they are both flaviviruses, and they cross-react. So when you do a test, you really don't know if it's dengue or if it's Zika. Or if you do a seroprevalence survey, you don't really know. You know it's a flavivirus. So we have been working with partners in how to improve diagnosis of dengue and Zika and all these arboviruses, new tools for vector control, new tools for risk communication and community engagement, and so on. And the last pillar is about building a coalition of partners, because, well, WHO is just one institution, but we work through all of you, right? So you are on the field, you are in the university, here you have the researchers there. So what we do is to bring all partners together, give some guidance in which are the priorities, and then hopefully people will follow, and then we will arrive to the same goal at the end. So as I was saying, pathogens are embedded in the ecological communities, and then you need to have a disease. You need to have the interaction, you usually have the interaction from the pathogens, the hosts and the vectors, which are the reservoirs, the vectors and the humans, and the environment. Usually the environment is the one that changes the most, so that's why environment is it's a key component. Of course, now everybody's talking about genomic surveillance, metagenomics. Yeah, that's great, but we need to first feel the basics before we first need to crawl, and then we can run, right? So we can integrate everything, but we need to bring the people who work in environment to help us understand which are the drivers of transmission, but also in this multi-sectoral approach, it's not just animal health, human health, and the usual suspects. With this complex disease, as we've been talking in these panels, we need urban planners that help us how to design a city properly. There's the new apartments that have been designed. We need to work with the people that provide water, right? So if you, like sometimes you need to go to the basics. So if you have a community where they don't have water supply 24/7, they need to collect water. So then your solution is not don't have these large containers. Then your solution will be to buy lids. So the containers, because otherwise how they cook? How do they take a shower, like a bath every day, right? So we live in a very heterogeneous world. So we have areas where, well, all the basic needs are covered, but then we have other places where they don't. So we need to start thinking in the problem as a complex problem. We need to bring education, the Ministry of Education, because if we start teaching, well, in all the levels, if you start in kindergarten or in elementary school, teaching that these mosquitoes might transmit diseases, that they are in clean water, and then homework can be that they go back to home and they look into this has been done in many places and it works. And then in the university level, then people will start taking smart decisions and wearing mosquito spray, for example. But when you live in an endemic area, because I live in an endemic area for a long time, you wear mosquito spray the first week because you are scared that you are going to after the first week, you forget completely about it. And also it doesn't smell good. So who wants to smell like mosquito spray? So then there is a lot of work that still needs to be done, right? So this multisectoral approach is way more than just environment and pathogens and the hosts and the vectors. And I wanted to bring this. Probably the disease ecologists in the room could do a better job. But what I wanted to show with this is that, if we want a group of diseases that are a sentinel for climate change, arboviruses are a great sentinel. And that's a way to start selling it and promoting this as a sentinel to measure the impact of climate change. Why? This is a classic temperature performance curve where you have a minimum temperature, then the optimal temperature and the max temperature. And then let's say that the temperature affects the mosquito biting or how quick they go from larvae to an adult. I'm not a biologist, I'm a medical doctor, but I'm learning about mosquitoes. So for example, if the temperature is too slow, let's say they don't bite too much or it takes too long for them to go from larvae to adults, then there is going to be a temperature where it's optimal. So then it's like when we have these outbreaks, right? Where the mosquitoes are biting, they are reproducing really shortly, the latent period in the mosquito is short, and then you have when it's a maximum temperature where it's not good anymore for the mosquito. So don't think this is a linear that the more the temperature increases, then the mosquito is going to, no. There is a point where it's optimal, and then when it reaches a certain point, the mosquito, it won't do any better for the mosquito. And why this is important? Oh, I put them in the wrong point. We'll switch around. So why this is important? Because the impact of the temperature will depend on which are the baseline conditions. Do we have a pointer? No. Okay. So for example, so in the x-axis is the temperature, and then in the y is the transmission potential from 0 to 1. So if it's 15 degrees, let's say it's too cold. If you increase 2 degrees from 15 to 17, it's okay. It's still not too hot, and it might be not be a lot of transmission. However, if you go from 18 here, from 18 to 20, then you can start seeing an increase in the number of cases. But if you have 23 degrees and you increase 2 degrees, that is going to really have an impact. So it's setting dependent. Even in this, it's like not one tool fits all, and the impact of climate change and the increase in temperature is not going to be the same everywhere. That's something that we all need to take into consideration. If the temperature, let's say, is 28 degrees, well, the transmission might be the same. So maybe what is driving the increasing number of cases is that you have a population that is being exposed before, and now you are having secondary infections, and that's why we are seeing more severe cases. And then it reaches a point where it's too high, and then transmission will decrease. But then we will need to understand first which is the baseline. So climate change is not the only factor that is increasing the incidence of arboviruses, as has been also said here. So the effect of climate change, because they are increasing the dengue infections due to high rainfall, humidity, and increasing temperatures. However, social factors such as unplanned urbanization, population growth, and other factors are having a key role on this. So there are things that we can do, right? Because when you blame climate change, it's so huge that some people, oh no, it's because of climate change. There is nothing we can do. Yes, there are a lot of things that we still can do, because there are other drivers that are other factors that are driving the transmission. So we have different scenarios. So one, areas without prior transmission. So let's say, well, last year there were cases very up north in France. So those areas, this is the time, and Madeira too, this is the time to prepare, because you still don't have the problem. So do you have to act now to decrease the number of mosquitoes, to work with your communities, to monitor whatever is circulating? But this is the time, right? Then you have the endemic areas where climate change is changing the seasonality. So for example, in Brazil, usually the peak of the dengue outbreak was about in March, usually. Well, not anymore. Now it's in January. So it's been 2 years where the season is starting earlier and is lasting longer. So they used to order, let's say, the insecticides and all the things that they need to control. They used to order them to arrive in February. Well, too late, because the season started in January. They lost the battle, right? And also in high altitude areas. So now I saw you were doing a project in Nepal, also in Colombia. In Colombia, we have a lot of mountains, and then the mosquito, I remember when I studied medicine more than 20 years ago, it was in 1,200 meters above the sea level. Then it went up to 1,600, then to 1,800, and now it's in 2,200 meters above the sea level. So soon, the capital of Colombia is Bogota, is 2,600 meters. So it's right up to this to get there. You have 8 million people that are completely naive. That is what happened in Nepal in some of the higher areas. So when we think about the expansion, it's not just in latitude, north and south, it's also in altitude. So keep always that in mind. I wanted to show this because this is the seasonality of dengue transmission in the Americas. And as you can see there, well, we have the countries with high transmission season in outbreak, but then there are a lot of, this is not the time for Central America and the Caribbean for having dengue transmission. So the season started earlier. And in some of the countries, some of the endemic countries, it never end. So this is the impact. And this is what I was telling you about the epidemic curves. So the peak is starting 10 weeks before we used to see the usual peak, right? So those are well, you might see an increasing number of cases because of many factors, but also seasonality is changing with climate change. And we saw this on the distribution of Aedes aegypti, that Madeira is there in red, and Turkey and Georgia and some other countries. But Aedes albopictus is really gaining a lot of space in Europe. Well, even in Geneva, we have Aedes albopictus now. I have a mosquito trap in my balcony to see if I can catch one. But last year, we had hundreds of cases coming from Italy, Ibiza in Spain, Madeira had an alert, and so on. So taking into account all of this, the aim is to prepare and be ready to control for the next arbovirus outbreaks if the next arbovirus is an arbo. It's the next disease X is an arbovirus. So we have been working in this hotspot mapping, global hotspot maps. So we open a collaboration with multiple modeling teams from all over the world. This was led by the London School of Hygiene and Tropical Medicine, that they have been doing these risk maps since 2013, and they have been updating them. So we asked them to update these global suitability maps for dengue, Zika, chikungunya, and yellow fever. And so they use temperature, humidity, vegetation index, population density. The model was adjusted by surveillance bias, so how close the hospital is, because that impacts the reporting of the cases, presence, absence of the mosquito, and so on. And this has been done for other pathogens, because, the idea was to have a spillover of pathogens with epidemic and pandemic potential. So you see here CCHF, Ebola, Hepanipavirus, Lassa, MERS, Marburg. So we have a huge list of pathogens. But as you can see, there is how the risk, for example, in the south of the US is increasing. Then if we go here, this one is still not publicly available because we are validating with the countries. But this is how Europe looks. So we are not expecting that Europe is going to be like Brazil, right now. However, the risk is there. And always remember that your risk of introduction will depend on how much transmission there is somewhere else. Because if with the current outbreak, in the current global emergency in the Americas and Southeast Asia, the probability of introduction during the summer increases, right? So this is the time to start killing all the mosquitoes. Remember, if we don't have mosquitoes, we don't have dengue. With Zika, we have sexual transmission of Zika. But with dengue, if there are no mosquitoes, there is no dengue. So all these areas that are here with the little spots, they should be right now controlling the mosquitoes. So when the travelers start arriving during the summer season, then you don't get these clusters of arbovirus transmission. Okay, so for the yellow fever one, we included the distribution of the non-human primates in the Americas, but also in Africa. And the same with Lassa, we included the rodents, and the same with the other zoonotic diseases. So really we are thinking in, these are nice maps, and this paper I think was submitted to Nature or something like that. But it will be really nice having in a paper. But what we really want with this is to how countries can actually use this first to look for these pathogens. So if they have the environmental suitability to have these pathogens, they should be looking at it. They should strengthen their surveillance system and start looking for it, strengthening the lab capacities, also start training the doctors in the hospitals to detect these kind of diseases. Because if you have never seen a dengue case and you have never read about dengue, it will come in front of your nose and you will never do the diagnosis. So, I don't know. I think I have time for a joke, but no. The first time I actually started doing this in my first job. My first job was in the Colombian Amazon, in the border with Brazil, in Leticia, in front of Tabatinga, and one day a patient arrived. I was the only doctor in town, obviously. Because we need to work for 1 year in a rural setting before we get our medical license. So, I went to the Amazon, and then one day one patient arrived, and he looked like he had dengue. I was like, he has dengue. But he didn't look well, so I hospitalized him, And then at the next day, he had jaundice. So I say, okay, dengue plus hepatitis. And that was my diagnosis. I have never seen a yellow fever in my life, just in the books. But then I was doing something else. I was looking to another patient, and then it just clicked that it was yellow fever. But it's because I was reading and I was interested in fact. Otherwise, it could have passed like a hepatitis. And then I had to go to the One Health approach. I have to go to the jungle to look for the non-human primates and take samples. And then I learned about the mosquitoes in the Amazon, and then I got passionate about this. And 22 years later, I'm still talking about mosquitoes. So don't give up. So yeah, I think we need to always think in a complete way and look at the full picture. And we are not just looking at this. These are other arboviruses that are currently circulating and causing human disease. So we have Japanese encephalitis, West Nile, Crimean Congo hemorrhagic fever. In the Western Pacific, I live in Australia for some time, and I live right next to the Ross River. So there is a Ross River virus that is the Australian cousin of chikungunya virus. So it looks exactly like a chikungunya, but you just find it in Australia because most of these Aussie and Western Pacific viruses, the reservoirs are the marsupials. So that's why the kangaroos, the koalas, so then you just find them there. But they are circulating all the time, and you just need a mutation or the virus adaptation, and then you start having transmission. Then in the African region, we have Rift Valley fever, yellow fever, yon, which is also an alpha virus. Currently in the Americas, we have Mayaro virus, and we have an Oropuche outbreak in Brazil currently. No one has talked about it because it's not an Aedes-borne, but Oropuche, it was usually endemic in the Amazon, and now is going in the south, and we're still figuring out, and of course there is a lot of research going on, see if there was a change of the mosquito, or there is a change in the virus, or what is happening, why is it moving from its usual size. And then all the encephalitic viruses that we haven't mentioned, all the neurotropic arboviruses. We had an outbreak of Western equine encephalitis in Argentina and Uruguay few months ago. So they are not in the news, but we are monitoring everything because any of these can be the next disease X. So for pandemic prevention, remember always that 70 to 80% of these infectious diseases have a zoonotic origin. That pandemics always start and end in communities, so the communities are key in any of these activities for preparedness, prevention, and control. The multi-sectoral approach is key. Cross-sectorial collaboration and coordination, community engagement, and partnerships. Sometimes we don't know how to do something, but we know a researcher that can do it and someone else that is doing the same. Let's partner and let's work together. And also breaking some of the silos, right? I think we have gained a lot of space in breaking the silos, but there is still a lot of work that needs to be done. You have people working exactly in the same institution and they don't talk to each other. So we need to break that. And thank you very much for your attention.
Thank you so much, Diane, for an amazing talk. I think it's been great to get this global approach, which was way beyond just mosquito-borne diseases and took us into the global world. So shall we have just one last question, and then we close the session, and we have a closing remark, and then it's the drinks time. So anyone has a burning question for Diana?
What's your take on SITs? You've mentioned Wolbachia, and then you've mentioned genetically modified mosquitoes. How about the sterile insects techniques? And the second is, why is our respiratory viruses distribution also anticipated by a couple of 2 to 3 months? Because if you look at influenza in the last season, was a huge epidemic and huge circulation in January as well. So why would that be the case? Sorry, 2.
No, it's okay. No, I think there are a lot of new technologies and new tools that are currently under evaluation. So I think we have to wait for the evidence. Wolbachia is very promising. and all the gene drive, and I think they are all promising. What we need to understand is which is the current biology of the mosquito in that specific town, and then if anyone is planning to introduce any of these new technologies, they have to start thinking that they need to work with the community at least 1 year in advance, because we've been telling people to kill mosquitoes for decades. And now the government is going to release mosquitoes. And they are going to release mosquitoes that are genetically modified, right? So there is a lot of work that needs to be done with the community before we even start implementing all these tools. So they have, and another thing that worries me is that we still don't know how often do we have to release this. Because it's not like I release once and then nature will do the rest. No, you need to start, you need to figure out if it's every 3 months, every 2 months, and also evaluate the cost effectiveness, right? As everything that we do in the government, they are going to invest a large amount of money, but then after 3 weeks or after 3 months, everything is gone, then what is the investment? So we need to work with governments, with communities, and evaluate the effectiveness of these tools in these specific settings. And there are guidance that are currently under development by the vector control unit. And the second question was about flu. Well, the thing is that in the pandemic, everybody was washing their hands and everybody was wearing face masks and everybody was keeping distance and so on. So we lost a little bit about the immunity for flu. So now, COVID is still circulating. That one is another one that is not gone, even if we don't want to talk about it. And then flu and SRV and all the other ones are keeping up, because now they have a huge population that are completely susceptible, and now they are catching up for those 3 years that everybody was worried about COVID and doing activities to prevent COVID transmission. Yeah.
One last question.
Through your presentation, we could see the numbers of arboviruses increasing in the south of United States and south of Europe. Do you think that the fact that those countries don't coexist for so long with arboviruses, with mosquitoes, made them unprepared to face the vector control? And also, do you think there is undercounting or underreporting of these numbers?
Yes, to both. So the first one is that the doctors in Italy, if they see someone with fever, the least they are going to think is in dengue, unless this person have traveled to Thailand or traveled to any of the endemic countries. And that's how it is in Europe, right? So we need to start training, and that's part of the preparedness in training the doctors in start thinking about these diseases, because what you don't think, you will never diagnose, right? And the other one, they don't have the experience controlling AIDS. So in the Americas, for example, we have experience from the eradication of yellow fever. So it's almost 80 years of experience. So whenever Portugal needs support, they can call Brazil, come and help us because they are still on time. They can still manage the issue. The risk is there, the mosquito is there, but they don't have the large outbreaks yet. And the same for the other countries. So this is the time to learn to get the lessons learned from the countries that have long experience in what to do and what not to do, and start controlling the mosquitoes to prevent further introductions. So also dengue, most of the infections are asymptomatic the first time. So there might be a lot of circulation, and we really don't know. Maybe we are catching the ones that are classical, but there might be some other underlying transmission that we are not catching.
It was a really short question and a really short answer.
Very fast. Do the current prediction models can capture that advance in the starting of the
season?
Yes.
Well, now they do, because they have been 2 years where the season has started earlier. But But 2 years ago, it was not early enough. And a lot of people had to go to the hospital. There was a very large chikungunya outbreak in Paraguay where hundreds of kids passed away because there is vertical transmission of chikungunya. So at the beginning, we didn't have an early warning system to actually detect that it was going to be a season starting earlier.
So
now we do.
Next year we can predict
I think for next year, people should prepare to have an early start. Yeah.
Thank you so much to Diane. Please join me in applause to Diane.
Doing world-leading research with a collaborative, multidisciplinary approach for long-term benefit of humanity is what the Institute for Risk and Disaster Reduction is all about. We look at what causes risk and disaster, what are the consequences of risk and disaster, and how can we catalyse change. And being here today, I can see that the MIWA project exemplifies what we do. All the panels and the speakers have emphasised the need for collaboration, the need to work across disciplines, across sectors, collaboratively with the people we're actually trying to help, and to actually have impact right at the centre of what we're doing, to have the people at the beginning, or it won't work. We'll get cats coming along and ruining everything we're trying to do. So this project, and thank you to Patty and all the collaborators, the speakers today, but also the wider team, because I know there are others who part of the team who weren't here today. I think this was such an important project, and it's the beginning of a lot of great work, which just exemplifies what we're trying to do, what we're all trying to do. And I'm going to echo the words of the earlier keynote where we said, you know, it's our duty or our responsibility to leave things better than where we started. I've slightly modified it. I couldn't remember the exact phrase. But leaving things better than we came is the duty of every single one of us. I believe that for every single person on the planet. And if we can do that through this kind of work, then we are going to achieve that. Thank you so much. And also to all the people behind the scenes who have been helping. I know you've all been running around to make this happen. Thank you to everybody. Thank you to attending. And let's enjoy the reception. Thank you.